Hello, everyone, and welcome to another episode of Faces of Phyla, where we discuss the confluence of phages and acne and the latest research on the microbiome. My name is Yug Varma. I am the founder of Phyla and the host of this podcast series. I'm a scientist, I'm a microbiologist, and after spending a decade or more in academia, I decided to jump ship and start a company based on the microbiome. Phyla focuses on acne and other chronic bacterial skin diseases, and we use phages to modulate and recalibrate the microbiome to a healthy state. Today, it is my honor to be joined by Dr. Hilary Baldwin, who is a person who needs no introduction in the derm community. I will try, though. Dr. Baldwin is a board-certified dermatologist and medical director of the Acne Treatment and Research Center in Brooklyn, New York. She's the clinical associate professor of dermatology at Rutgers Robert Wood Johnson Medical Center, and she has interests in acne, rosacea, keloidal scarring, cosmeceuticals, and the skin microbiome, amongst many, many others. She's a frequent national and international lecturer and visiting professor, and her work has been published extensively in dermatology journals. Dr. Baldwin served as a founding member, a board member, and second president of the AARS, the American Acne and Rosacea Society. So welcome, Dr. Baldwin. It's a pleasure to have you. How are you doing?
Thanks very much. I'm sorry, I'm in my freezing cold car in New York, so I'm all bundled up, but I'm ready to go.
Amazing, amazing. Well, let me start off with the most obvious question. What are you seeing most in your practice in terms of, the kind of acne you see? Is it adolescent, hormonal, cystic, pregnancy acne, adult acne? What's the split?
All of the above. I have a lot of adult women with acne. That's, I guess, my primary population, but I see everyone. All the things that you just mentioned, very commonly in the practice.
Do you approach treating these different types of acne differently?
Yes. With the adolescent, of course, you're at the beginning of a very long journey. And we always refer to it as a marathon, not a sprint. So you have to think about how to care for them now. Sometimes when they have very mild acne, all the way through moderate into severe acne, sometimes, and the use of isotretinoin. With the adult female, you're dealing with a completely different group of people. These are people who often have never had acne before in their lives, and they get hit all of a sudden in their 30s or 40s with a face full of acne. Certainly not what they were expecting as they entered the aging process. They have a whole different set of needs and requirements, not the least of which is their psychological well-being, as it's very uncommon to have this kind of acne at this age, and they look different than their colleagues, than their friends, and it brings up a whole host of different psychological impacts. I also see a lot of what I refer to as last hurrah acne, which is a woman who's been free of her acne for many, many years, and all of a sudden at 50, just as she's starting to go through perimenopause, the acne comes back with a vengeance or comes for the first time. So we're seeing the whole host of acne patients. I suspect that the pathophysiology of the adult female acne and the last hurrah or menopausal acne is different somehow than that of the teenager, but we certainly don't know in what way. And currently, all three of those forms respond to similar medications.
So speaking of the different medications and how they might treat acne differentially, what's your go-to for treating acne? Or, obviously it's not a one size fits all, but
Right.
How do you use your armamentarium to address that?
Well, it definitely isn't one size fits all, but we have to recognize that we don't have all that many different agents in our toolbox, do we? We have quite a few topicals, we have a handful of orals, and then we have procedural therapy. And the art of treating acne is not so much what you use, but the combination in which you use them. So, if we start with segregating the patients by mild, moderate, and severe. With mild, we're talking about topicals, usually retinoid and benzoyl peroxide, maybe the addition of clindamycin, as long as it's used in conjunction with benzoyl peroxide, perhaps adding clascoterone as well to reduce sebum production. And then as we go to moderate, we're throwing in oral medications. And then, of course, severe, we're looking at orals plus topicals and the possibility of isotretinoin. So it all depends on the severity, the type of lesions the patient has, but we also have to throw in the quality of life issues, as well as the life of the patient. You know, what is their life like? Do they play sports? Are they wearing football shoulder pads that are exacerbating their acne? How much can they afford to spend? Can we afford to give them the Rolls-Royce branded brand new products that have better efficacy and tolerability? Or are we limited to generic products? So all of this stuff has to be figured out when we're dealing with the patient sitting in front of us.
What gaps do you see that exist for acne treatments?
Well, that's a very good question. We had, let me just back up 2 years ago. We had two things on our wish list. One was a topical sebum inhibitor, and the other was finally giving us all three of the topicals that we use most commonly, a retinoid, benzoyl peroxide, and clindamycin, into one container, so that the patient was only being asked to use one product a day. And both of those things on our wish list came true in the last 2 years. So we're sitting pretty right now. But we still don't have a way to take care of our acne patients with very little in the way of side effects and good efficacy, and maintaining our role as good stewards of antibiotics.
Yeah, and speaking of that, I think JDD last month published a supplement that you were a co-author on, which was reevaluating oral antibiotic use in acne management.
Yes.
Obviously, you know, dermatologists prescribe a good proportion of the antibiotics that are in use today, and that is primarily for acne. And we know that, you know, antibiotic stewardship is so important. So yeah, can you comment on where you see oral antibiotic use is in acne management, which way it should go?
That's a great question. You know, the major problem is that oral antibiotics work darn well in the treatment of inflammatory acne. So, and they're easy to get, and we have numerous formulations that work very well with very few side effects. So it's a very big temptation when somebody has more severe acne, especially inflammatory acne, or acne that's involving, let's say, not just the face, but the chest, the back, and the arms, where putting on topicals gets a bit daunting. So the baseline problem is that they work really, really well. But we know, again, that this is a marathon, not a sprint. And the use of oral antibiotics over the long haul is not going to be possible. So we're going to have to figure out a way to discontinue them in the near future, in the months to come, and have to have some kind of an alternative. We can't just say, here you go, use the antibiotics, get better, and then 1 month later we have to start this all over again. The bottom line, I think, is that the use of antibiotics in the treatment of acne, especially the tetracycline class of antibiotics, is kind of futile, isn't it? I mean, the C. acnes is going to come back, and you're not going to be able to discontinue your oral antibiotics unless topicals are holding the patient. So, as well as the fact that the antibiotics are killing all C. acnes, and as we well know, there are subtypes of C. acnes, one of which is associated with acne and one is associated with skin health. And unfortunately, when you utilize the antibiotics, you're killing all of it. So you're killing the good guys as well as the bad guys. And wouldn't it be lovely if we could figure out a way to target just the bad guys and leave the good guys alone, that are reducing the pH of the skin, reducing the likelihood of Staph aureus growing on the skin, reducing biofilm formation, all sorts of really great things from the subtype 2 that's associated with skin health. So that's I think at the top of my wish list, a way to kill just the type 1 C. acnes subtype that's associated with acne and leaving type 2 alone.
Yeah, I mean, I think you're right. That's the dream. And C. acnes plays such a big role in the sebaceous skin microbiome, which is the skin microbiome of the face. The fact that it is present at the rate of 80 to 90% of all bacteria on our face in adulthood for pretty much every person on Earth is very significant. And the fact that it also plays a major role in its overgrowth in acne, I think is also frustrating, because you pointed out that antibiotics, even benzoyl peroxide, are very effective in treating acne. This has been shown over decades. And their mode of action is antibacterial, not the only one, but primarily. And the fact that this results in a great improvement in acne, I think, points to the good and the bad, right? The good is, yes, it's going after the main culprit, but the bad is it's, as you said, killing good and bad indiscriminately. And it's not just killing the good and bad strains of C. acnes indiscriminately. It's going after staph epidermidis and other corrupting bacteria, and all the other commensal good bacteria on the skin. So,
and gut flora. So we can't forget that the gut is getting hit as well.
Absolutely, yeah, and with the gut, there's so much dysbiosis that happens there as well that it's really important, especially for systemic antibiotic use, to be aware of that. And I really see the microbiome as this garden, right? That if you saw a weed in your garden, you wouldn't set fire to your whole garden to get rid of the weed. That's ridiculous. But you would just pluck out that weed, replace it with a patch of dirt or a patch of grass, and you're done.
Right.
And I think that is something, switching to phages, the power of phage technology and the power of this approach of using phages is that they can do exactly that. They can go into your garden, find the weed, and scoop out that weed without hurting the good plants that you want, without hurting the lawn that you've cared for so deeply. And even with phage use kind of continuously over time, because they don't have harsh side effects, because they only go after the C. acnes and not anything else, it's really, really important that we kind of recognize this as another tool in our toolbox and kind of spread awareness for this, but also understand its role in the treatment of acne. And one more thing I wanted to point out was, you had mentioned, what's our dream is if we can have something that treats or kills the pathogenic C. acnes strains without hurting the probiotic ones. That is the ideal treatment.
Right.
The way that phages kind of figure in that is at least the phages we use and the phages that we know about in literature that exists that go after C. acnes, they all kill multiple strains of C. acnes, but the probiotic strains of C. acnes that are differentially found on healthy skin actually contain CRISPR modules that make them resistant to these phages. Those are the only strains of C. acnes that have these CRISPR modules. And so the pathogenic strains are actually much more susceptible to phages, and the probiotic strains naturally have some sort of resistance. So this is just how it shook out in the natural world. I'm sure this has some correlation with, who has the good strains, who has the bad strains, and who's lucky enough to get them. But I think, I wanted to also close the circle in the observation that there are some good strains that are present on healthy skin, bad strains that are present on acne skin. The other crucial difference between healthy skin and acne skin is that C. acnes phages are quite abundant on healthy skin, and they're deficient in acne skin. And so this organism that preferentially kills acne bacteria is somehow, much more abundant on healthy skin. And I think the full piece of the full puzzle is those two pieces clicking together. So what do you think about microbiome therapeutics? I know that we've known about the microbiome, and there's been a lot of interest in the microbiome for the last 15 years or so, starting with the gut microbiome, but now also in the skin microbiome. And I also know that there are a number of companies, technologies, approaches leveraging the microbiome space that are trying to develop, products and approaches to acne and many other diseases. So what do you think about microbiome therapeutics? Is it a fad? Is it here to stay?
Well, that's a great story. The data will eventually let us know the answer to that question. It makes a ton of sense. It makes a lot of sense to think about using the healthy form of C. acnes, the type 2 form subtype, as a probiotic, putting that on the skin. It makes sense to use the phages to kill the unhealthy, the type 1 C. acnes, or maybe both of them together. Maybe emptying out the pore first, using a pore stripper to remove the contents of the pore so that it's easier to get the probiotics in to do their job. I think this is all very exciting, and it would be a way for us to control acne without using any orals and without impacting the healthy portion of either the cutaneous or the gut, for that matter, microbiome. So wouldn't it be wonderful? It's a dream.
Yeah, I think I share your optimism there as well. I think it's an exciting road forward. It's a lot of, I think, innovative white space for people to discover things that are more effective, that are probably safer, that are probably things that are more tolerable. And like you said, not going the oral route or eschewing the oral route, or maybe having something that goes the oral route but does not do as much damage as antibiotics can do in terms of gut dysbiosis.
Exactly.
What were your initial reactions when you learned about Phyla's phage-based approach? Were you optimistic? Were you skeptical? Had you heard about phages before?
I had heard about phages before, but much of the information did not come from the US or the EU. I was seeing information from Georgia and from, I don't want to say places that I wasn't 100% sure were carrying out the studies very vigorously. So I was a little bit skeptical, but the idea was extremely sound and totally rational. And I was hoping that somebody like you was going to come along and do it in a good way, with studies conducted appropriately, with double-blind studies and vehicle controls and all that kind of thing, so that we could really tell whether these products were working.
Yeah, and I think that's a very important piece of it, because although phages and phage therapy have been an idea and put into practice, in fact, for over 100 years, their scientific history is that they have been deployed in Russia, in behind the Iron Curtain during the Soviet era,
Yes.
and in Georgia, in the country of Georgia, for decades, where I think the bulk of the practicing side of phage therapy resides, and that history resides. And there's a language barrier. They weren't they did trials that weren't adherent to, I guess, modern standards of double-blinded, randomized, controlled experiments.
Right.
And so obviously that has to be taken with a grain of salt, and that is the data that exists. And I think we've been very excited to generate some of the first and only maybe data on phages in the modern era, but doing so in a rigorous way. We have some, compatriots, which is awesome, because I think more information, more data, more persuasive kind of science behind this technology is only going to bolster and embolden dermatologists to take this up and use it in their practice. And I think with our clinicals that have been accepted for publication in JDD and should be out soon, that gives a dermatologist an opportunity to take a look for themselves, right? Read all of the science, read all the caveats, read all the kind of tempering statements to the argument, and then make the best decision for themselves. Now, Phyla obviously can be used as a frontline sort of treatment on its own, but it's also a great adjunctive treatment, right? And I think one of its powers is because it has a unique and non-interfering mode of action. It can be used even in combination with antibacterials like benzoyl peroxide and antibiotics. And I think the utility there is, although BPO and antibiotic are broad spectrum antibacterials, once they kill a number of bacteria on your skin microbiome, your skin microbiome starts to grow back slowly, right?
Yeah.
And at that point, the C. acnes might run away with it. It might overgrow so fast that it further suppresses and causes dysbiosis in the microbiome. And with phage use, you're suppressing that overgrowth and allowing the other good bacteria to grow back. It's kind of like a weed suppressor that
Right.
allows the flowers and the plants to grow back. So how do you see Phyla as an adjunctive treatment? What would you pair it with, or do you feel like it's a pretty good sort of broad treatment to pair with other RX?
Well, I mean, in its essence, it will replace, I think, the topical antibiotic that I might have used in a combination, because it would be taking care of the C. acnes. So normally we're combining our topical antibiotics with a topical retinoid. So for me, the best compatriot is a topical retinoid of some sort to help with the hyperkeratinization, or perhaps clascoterone as a sebum inhibitor, or maybe all three together. But I think it would take the place of hopefully of topical antibiotics, as well as topical benzoyl peroxide. I love benzoyl peroxide, but it is, after all, an oxidant, and we worry or we think about that. And it has the unpleasant side effect of bleaching fabric, which is, seems like a minor issue, but is actually, it interferes with people's lives. So if we could replace it, wouldn't that be wonderful? So that's where I see it as an adjunct.
Yeah, that's very true. And I mean, although it seems like a minor inconvenience with the bleaching fabric, if you're applying it every day and then,
Exactly.
oops, something happens or something falls, it's a huge problem.
Yep.
How do you explain Phyla to patients?
It's a little tricky. I don't want to use the word virus if I can help it, because I don't want to make them nervous. They shouldn't be nervous. They don't have to be nervous, but I think it's inherent in the process. So I talk about it as being a natural way to help to decrease the number of bacteria that are living in the follicles, that is a major part of the acne pathophysiology. And I just sort of leave it at that unless further questions are asked.
Have you had any patients share their results with using Phyla? What has your experience been?
I've had people come back who are very happy with it. I use it frequently in, we all have patients who come in with relatively significant acne who only want natural products. And frankly, in the past, that's driven me partially crazy, because we don't have natural products that do a great job in treating acne, in my experience. So here I finally have something where I can honestly say that it's a natural component of the skin that you have augmented to do a better job.
Amazing. And what do you hope would be the standard of care for acne in 5 years?
Wow. No clue. I'm hoping that the use of probiotics and bacteriophages are going to take off, and that it's going to be a clear winner and a way in which we're going to approach acne, utilizing that as well as a topical retinoid, which I think is a good, first of all, it's excellent for the treatment of acne, obviously, but also it has many beneficial effects on the skin, as well as anti-aging effects. So the two of them together, I think, if that was effective in controlling acne, that would be the place that I would go. Another place that I would go is more frequent and earlier use of isotretinoin, as opposed to utilizing oral antibiotics, and also taking advantage of anti-androgens like spironolactone and clascoterone to try to help control things without, again, having to resort to oral antibiotics. I think it's crucial for us all to be good stewards of antibiotics, and we need to take that very seriously and do our best. Because as you know, dermatologists are the #1 prescribers of the tetracycline class of antibiotics in the United States. And although we make up only 1% of the population of physicians in the US, we write for 5% of all oral antibiotics, and that needs to change.
Yes, I mean, that is, I think, a very sobering and serious prescription indeed. I want to sign off on a lighter note. What's the most outlandish thing that you've had a patient tell you they tried for their acne?
Milk of magnesia and tomato paste.
Wow, that sounds like a food recipe, not a acne treatment.
Avocado, mayonnaise, and toothpaste, of course. That's a biggie. Not sure what all of these have in common, but I've heard all of them. And unfortunately, they came from patients with whom I spent about a half an hour talking about pathophysiology of acne and this wonderful regimen I was going to prescribe for them. And they come back with toothpaste. So I'm happy that we have now something to recommend that that is a more natural product, so that they can feel, those patients who feel more comfortable with what they consider to be a non-medication will have a place to go and a product to use.
Yeah, maybe the only thing that they have in common is that they didn't work, and probably made the problem worse. But
yes.
Yeah, I'm happy that phages and phyla are another tool in your arsenal. It's something that I think innovation in the last few decades has sorely lacked, as innovation has come storming in other areas of dermatology like atopic derm and,
True.
I think there's amazing innovation. With acne somehow, which is the #1 dermatological concern, there's a lot of work to be done.
Yep, very, very true. We're very jealous of our atopic and psoriasis compatriots. That's definitely true. They got all of the brand new gorgeous drugs, and we're still, our acne medications, benzoyl peroxide, 65 years old. Isotretinoin is 45 years old. So we're really in the dark ages, as you said.
Yeah, I was at a conference and someone said, oh, benzoyl peroxide is 1930s, 40s technology. And retinoids or Accutane is 1980s technology. I was like, ooh, when you put it like that, ouch.
Really? I mean, they're still bona fide excellent treatments, so that's why they haven't gone away. But innovation is not exactly the name of the game in the last 10 years, with the exception of the 2 new topicals that we mentioned, and of course, the use of phages.
Yes, and we hope to keep marching on, improving our knowledge and the science behind phages. Thank you so much, Dr. Baldwin. This was a pleasure. And
my pleasure.
Yeah, and I know that a lot of people are going to take a lot of information and pearls out of this. So thank you.
Good. Excellent. Thank you for inviting me.
Yeah, and we'll see everyone soon on another episode of The Faces of Phyla. So thank you so much. Bye.